So, uh, so, um, so we are going to speak today about sequential versus upfront chemoimmunotherapy for advanced bladder cancer. Next slide. If you see the development of the treatment in the advanced bladder cancer, the first significant development happened in around 2000 when gemcitabine and cisplatin came into the picture. And then subsequently, for the first line, the next development happened after 20 years in 2020 when the Javelin 100 trial came, and we showed that those patients who are responding to the chemotherapy, if you give maintenance avelumab, there is improvement in the survival. Of course, there were some trials showing newer drugs in second line, but for the first line, these are the two important events. And now, if you see at the end of this picture, there is a rocket. And what they're trying to say that in 2023, the treatment of the advanced bladder cancer has gone up like a rocket. And that is what we are going to debate here, whether it's rocket or not. Next slide. So IO in advanced bladder cancer has multiple failed attempts. And if you see something which has been utilized multiply and multiply failed, we try to adjust, you try to improve the inclusion-exclusion criteria, you try to show ourselves better, and that is exactly what has happened with immunotherapy in advanced bladder cancer. And if you see the next slide, and this is the summary of all the trials which has been tried with chemotherapy and immunotherapy combination or immunotherapy alone in advanced bladder cancer till date. And if you see the right side, most of them are negative apart from Javelin 100, which was positive. And of course, Checkmate 019, where the chemotherapy nivolumab arm was positive. Now, what we don't know, next slide, is that the Checkmate 901 had another arm also. And unfortunately, that arm was given double IO plus IO and chemo. And that arm was negative. But unfortunately, nobody talks about it. We only talk about positive trials. We only talk about positive results. But we should know that these results are not common. There are very few trials, and Checkmate, I agree, Checkmate 901 is one of that trial which come positive. Next slide. Now, of course, as I said, the Javelin 100 was the 2020 trial, and it showed that for those patients who have responded to chemotherapy, the avelumab maintenance improves PFS and OS. And to be surprising, when you have subsequent trials, ideally this should be the control arm of the subsequent trials, that you give control arm the same thing which has been proven before. But it has not occurred, and you will be surprised to know that Thomas Powell was the PI for Javelin 100, and Tom Powell is the PI for the EV plus Pembro trial, which I think my colleague will discuss. So this is something which probably could have been different. We have to have a continuation of the treatment, that the control arm has to be standard, which is not done in these trials. Now, next slide. Now, let me tell you this concept that in bladder cancer, the choice of platinum matters. Whether we are using cisplatin or carboplatin does matter based upon these retrospective analysis. And what is the significance of this? I will show you next slide. If you look at the OS from the start of first-line chemotherapy in Javelin 100 trial, Javelin 100, there was chemotherapy given. Those who are responding, you randomized to avelumab versus no avelumab. But if you look at those who have, and Javelin, those patients required both cisplatin and carboplatin. So if you look at the OS from the start of the first-line chemotherapy, it is around 31 months. So remember this figure of 31 months for Javelin 100 trial, in which patients have received GemCis, and those who have responded received avelumab maintenance. Next slide. Now, so by the sequential chemo of Gem plus Cis followed by avelumab, you are going to get a median OS of 31 months. Is it not good enough? And probably a lot of us think that it is not good enough because of these two slides. And this was shown in ESMO 23, the one on the right side, the EV Pembro plus versus the standard chemo, got a standing ovation with a hazard ratio of 0.47. And if you see the median OS, which is 31.5 months, and it is still improving. So probably this will improve in the future. But if you look at the left side, the Nivo cisgem followed by versus only the cisgem, the median OS is only 21.7 months. It is early, it is 48 months, but if you compare with Javelin 100, it has a longer follow-up, but probably I feel that even if we have a longer follow-up, whether it will show further 10 months improvement as compared to javelin, it is slightly we'll have to see in future. But look at the hazard ratio; it is 0.78. Confidence interval going close to 0.6. Why don't you remember the hazard ratio? Please see the next slide. Next slide, please. Yeah. So if you see this, these are the OSH. Sorry, previous slide, please. One slide before. Yeah, so if you see the hazard ratio of the other chemo immuno trials, that atezo plus chemo or pembro plus chemo, it is around 0.83, 0.8. That means by virtually the hazard ratio of neuro plus chemo is 0.78, hardly difference of 0.05, and the trial has become positive. So what I'm trying to tell you is that all these drugs probably have similar results, and only why two trials have failed and one is positive is probably something which is into the trial design or the post progression therapies rather than the effectiveness of the drugs. Next slide. Now, if you see that what is the PFS benefit of the Gemsys versus and Nivo arm versus the Gemsys alone, and if you see the median PFS is 7.9 versus 7.6 months. So if you calculate, it is only 9 days benefit. And if you see the p-value, it is 0.0012. So for a 9 days improvement, we are getting a highly significant p-value. Then I must say there is something going on here which we need to look deep into. And next slide. What we need to see is what is the subsequent therapy for control arm, and this is for javelin. If you see the javelin's control arm, when the best supportive care was given, 72% patients got subsequent therapy, and out of that 72%, almost 73. That means significant number of patients got immunotherapy on control arm in javelin trial. See the next slide. But if you see the Gemsys arm, the control arm of the Nivo plus Gemsys trial, the Checkmate 901, hardly 20% patients got immunotherapy before progressions and 20% got immunotherapy after progression. So basically, it is the lack of post-progression therapy that may be contributed significantly to the so-called OS that has been seen in this particular trial. So now let us come to the next slide. What is the basic difference between giving a chemoimmunotherapy followed by immunotherapy maintenance versus giving chemo followed by immunotherapy is 6 additional cycles of immunotherapy which is given along with chemotherapy. So if you look at the PFS and OS curves for first 4 to 5 months, that duration of the first 6 cycles of chemo plus IO, there is absolutely no difference. So are we overtreating with 6 more cycles of IO? I probably think yes. And another important question is, what about those patients who have got adjuvant nivo? All of you must be aware that adjuvant nivolumab is approved in the bladder cancer in the adjuvant setting. So for those patients who metastasis after receiving nivo, can we rechallenge? We don't know the answer for that. The next slide. So what about cisplatin non-eligible patients? Again, no data for the same in Checkmate 901. Again, as I said, ideally control arm should have got avelumab maintenance. Better trial design would have avoided this debate only. We would have clear-cut answers. By giving IO only to those patients who are responding well to chemo, we are selecting good biology upfront and avoiding giving unnecessary IO to those with aggressive biology, less toxic and more cost-effective. Of course, we're in India. We have to talk about the cost-effectiveness. Next slide. So at the end of the ESMO 23, this is what is recommended, that if the patient is upfront presented to you, you give pembro plus EV, but at the same time, they say that the option of giving chemo followed by only avelumab is still there, especially for those who are so-called cisplatin unfit patients. Now, what is the problem with giving everything upfront? I will show you in the next slide. Is that this is the so-called flow chart in which you give ADC plus the chemo upfront and followed by chemo IO maintenance. What are you going to do when those patients who are going to relapse after this? We have hardly any options left after that. And then you say that you give platinum-based chemo in the second line, or you give maybe a rechallenge of IO. So unless and until you have a very good subsequent drugs, giving everything upfront probably is not going to work long term, and probably the overall survival will remain still the same because there is nothing to follow. And that is what you should think, especially when you are choosing these drugs, and you have to choose wisely. And I will come to my last slide. And as I know that Kumar is the judge of this, so probably the Javelin 100 is not going to be a winner. But as I said, eventually chemo followed by immunotherapy to those who are responding will be a long-term winner, especially in our country. That's what I say. Thank you.